Courtney, it's great to see you.
Good to see you.
Looks bright and sunny there.
Yes. I'm assuming it's very cold, or maybe not.
It's
so
cold, but we got the sun today, so we're gonna take it. Sometimes it's so cold the clouds can't stick around, you know, like
different kind of cold.
Well, everybody, welcome back after spring break. This time of year when like the heat doesn't quite know what it wants to do in the building. So some days it's just too damn cold.
Gotta have lots of layers.
Yeah, exactly. That's the way to go.
I feel like our weather here doesn't know what to do. One day it's like 30 degrees, and then the next day it's
yeah. Yeah, Michigan likes to tease us with like a 60-degree day, and like the Dairy Queen's open and you can go buy, and then it's like no 20 and ice storm. Like that's so but we stay. All right, let's give everybody one more minute, and then Abby will start our announcements, and then I'll introduce Courtney, and we'll get started. Do you want to make sure that we can share screen just real quick, make sure that's working okay?
Can you all see my slides?
Yep, that is perfect.
Great.
You can keep that up if you want to, because I'll need to see everybody while we're getting going. Although I've got my whole group here. So I'll get started by asking Abby to give us our announcements, and then I'll introduce today's speaker.
Sure. Hi, everybody. Welcome back from spring break. I have two quick announcements. The first is that we are still accepting applications for our Harburg Award, which, just a reminder, that is open for master's and PhD students who show promise in the study of the social and psychosocial determinants of health. I'm putting a link here to our website where you can find more information and find the application link, but feel free to reach out to me. Applications are due on March 20th, so make sure you get them in. And then my second announcement is that we will be having a graduation celebration for our CSEP grads and graduates from the Social Epidemiology Certificate Program on April 13th at 1 p.m. I'm attaching the flyer here. We will announce the winners of the Harburg Award. We'll have a little video commemoration for our students. And we are also inviting Kim Fox, who is a recent EPID alum. She's currently working at the William Davidson Institute, kind of more in the business sector. And so she'll be talking about the work that she's doing. So we hope you will be there with us. We are still working on where the location will be, but we will send that information out once we have it. I think that's it. So Bree, ready to go?
Yeah, thank you so much. So it is my pleasure today to introduce Dr. Thomas Tobin. She is a medical sociologist who uses mixed methods and transdisciplinary approaches to examine psychosocial sources of risk and resilience and their impact on the health of Black Americans over the life course. She has developed the racialized self-awareness framework for race-based stress coping and health, which clarifies environmental, sociocultural, and behavioral processes by spotlighting this construct of racial self-awareness, which is the heightened sense of awareness of one's racial minority status within a majority context. She's currently developing new measures to assess the health consequences of racial self-awareness and other race-based stressors and coping experiences within nationally representative samples of Black Americans. I know Dr. Thomas Tobin from her as a scholar in the MIWI, the Michigan Integrative Wellbeing and Inequality Training Program, which I direct, and I am just thrilled to have her here to share this really exciting work. So please join me in welcoming Dr. Thomas Tobin.
Thanks so much, Bree, and thank you all for having me. Good afternoon to you. Still morning here for me on the West Coast, but I'm really excited to be able to start my day off with all of you and to have an opportunity to share a little bit of my work with you today. So what I like to do is to provide a bit of an overview of my program of research, which focuses on biopsychosocial pathways to health and longevity among Black Americans. And I'll start off with providing you with a little background as to the motivations for this work and the various theoretical approaches that guide my work. And then I'll share examples from some specific studies. And then I'll wrap up with discussing some future directions and where I'd like to ultimately take this work, with time at the end for hopefully some good questions and discussion. So as Bree mentioned, I have a pretty interdisciplinary background that incorporates my training in psychology, sociology, and in public health. In addition to being shaped by my various disciplinary orientations, like many of us, my research interests and how I approached them was and continues to be motivated by my life experiences. So I grew up in New Orleans, Louisiana, which as you know, has a rich social and cultural context, along with a very socioeconomically diverse Black population. And so for me, growing up there and then later experiencing significant loss and witnessing the devastation of Hurricane Katrina as a high school senior, really sparked my interest in wanting to understand and evaluate what the social stressors and the traumas that Black Americans experience across the life course, to really understand how those experiences shape health, well-being, and quality of life. And so in addition to being, there we go. So in addition to witnessing many of those challenges, I also saw that some individuals seem to actually flourish and even thrive in the face of adversity, demonstrating what the academics tend to call resilience. And I really became fascinated with trying to figure out what makes some folks do so well, despite everything that we think we know about them, suggesting that they should be experiencing the worst outcomes. And in particular, I wanted to know, so what were the structural and community-based and the psychological factors that protect health, and how do they promote resilience and positive outcomes among Black Americans? And so by understanding these protective mechanisms, I believe that we as public health researchers and practitioners are in a much stronger position to leverage resources that communities already have at their disposal to improve outcomes and to reduce inequalities. So to do this, I draw on and integrate numerous theories, frameworks, and perspectives, some of which I'll just briefly highlight. So first, as a medical sociologist whose research focuses on Black Americans, my primary orientation recognizes that racism, not just race, is a fundamental cause of disparities in health. And so while that is increasingly becoming more and more recognized within public health research, the mechanisms that are through which racism shapes health hasn't always been as clear or even widely considered. And so when we say that racism is a fundamental cause of health, we recognize that it works through multiple levels, and that ranges from structural to interpersonal to the individual levels. And we also consider the ways that these processes can vary over time. So to illustrate this point, here's a graphic that I like to often share when I'm teaching about the multiple mechanisms linking racism to health. And so we can see here, ranging from the structural or institutional manifestations of racism, when we think of things like residential segregation or disenfranchisement, we think of interpersonal racism and unfair treatment, like discrimination, all the way down to the development of racial identity at the individual level. But as I'm sure you've noticed, these images are what a lot of folks often think of when they think about racism. So these, more historical or traditional forms of really blatant racism. However, as I think more and more folks are recognizing, racism more often can look like this, right? So many of those same mechanisms, from the structural with differential access all the way down to the individual level, to racial identity, which is becoming increasingly more nuanced and complex, which we see with Rachel Dolezal here. And so really understanding how these mechanisms and how they vary over time in the different ways that folks think about and make sense of race and racism are really a focus of the work that I do. And so when we think about what all of that does for health, we might draw on the foundational work of Dr. David Williams and later by others like Phelan and Link. We think about the ways that racism not only creates differences in status, like socioeconomic status, but also how it can manifest in racial differences in the way that these various resources actually impact health. And so we often see that with work on diminishing returns. For example, like when we see college educated Black folks earning less income or having less accumulated wealth than white individuals with the same education levels. So in recognizing that health risk and resources are not one size fits all, and evaluating the ways that systemic racism leads to distinct health patterns among Black Americans in particular is really a central focus of my work. As a medical sociologist, I also probably most heavily draw on the stress process model, which is a prominent framework used in medical sociology and the sociology of mental health in particular, to really understand how inequality arise from differences in individuals' exposure to stressors. And then also how differences in protective resources, like social resources, like social support or more personal individual level resources, like coping, self-esteem, John Henryism, how those all work to contribute to group differences in health. Within that framework, we consider the life course and how the accumulation of stressors can vary over time. We also think about the ways that individual intersectional either identities or social locations contribute to differences. And then part of this also includes the recognition that stress isn't just about how people feel, but recognizing that it's also operating at the physiological levels to produce differences in health. So through various biosocial approaches, which are becoming excitingly, more and more common in medical sociology, by using, biomarkers, to assess some of those physiological processes, we're able to see how these experiences become embodied or get under the skin, as folks say. And an added level to my work is the consideration of a lot of these psychological processes, such as stress appraisal or how folks perceive and cope with these processes. So that brings us to, the utilization of biopsychosocial approaches to assess health. So to better understand the health and well-being of Black Americans specifically, I integrate all of these approaches with classical sociological theories that explicitly consider the complexities of the Black lived experiences, particularly draw on W.E.B. Du Bois's work on racialization experiences like double consciousness, really provides us with some distinct insight into how the experience of being Black in America contributes to kind of some distinct experiences among this population. We also see a lot of this reflected in more recent considerations of the roles of race and racism and how Black Americans navigate racialized spaces. And so Du Bois really laid the foundation for a lot of our contemporary understandings of how race and racism shapes health, particularly through a lot of qualitative work on the Black middle class. And research on this work has been especially useful because it provides insights into what we call socially incongruent statuses. So how being Black and which is a marginalized, a racially marginalized status versus having higher socioeconomic status can confer both privilege and marginalization at the same time. So it really challenges our ways that both race and SES can work together to shape folks' lived experiences. So all of this I highlighted in my very first published article back in 2015, and it pinpointed a lot of the challenges faced by the Black middle class. And so my early work on that group is what alerted me to some of the unexpected health patterns experienced by many Black Americans, and brought me to my current program of research, which primarily focuses on the race paradox in mental health. So what is this paradox? So when I refer to the paradox, I'm specifically referring to a body of evidence in research demonstrating that Black Americans experience lower rates of psychiatric disorders, in particular major depressive disorder, but report worse ratings of subjective well-being, such as psychological distress. And so we see this discordance between distress and disorder as paradoxical for a few reasons. Mainly because we see that Black folks face many of the psychosocial risks associated with poor mental health, like exposure to stressors, low socioeconomic status, and at the same time, distress and disorder have been traditionally thought to have overlapping etiologies or causal pathways. And so these patterns raise the possibility that these outcomes may have some distinct etiologies, and are possibly shaped by group-specific risk factors among Black Americans. And research has posed several possibilities to explain some of these pathways, summarized here. So, for example, the idea that perhaps physical and mental health are not linked the same way across racial groups, perhaps due to differences in lived experience. Perhaps distress and disorder are not linked the same way. Health risk and resources may have different impacts on mental health versus physical health. And then these outcomes just may be shaped by distinct group-specific risk factors among Black Americans that we aren't assessing when we're doing a lot of our comparative studies. So in my program of research, I consider these various explanations to shed light on the paradox and to ultimately identify the protective mechanisms that may contribute to some of these positive mental health outcomes we are observing among Black Americans. So I have three main research areas. The first is examining psychosocial pathways to embodiment. Second is examining health risk and resources across the life course. And third is which focuses on racialized stress and coping processes among Black Americans. So I'd like to highlight some of these projects and findings from these different research areas. So in this first area of research, I examined the determinants of and the links between mental and physical health outcomes, as well as the biological processes through which they operate. And so I consider biomarkers. And I work to clarify the ways that social and psychological experiences become physiologically embodied, manifest into psychiatric disorders and chronic physical health conditions, and ultimately contribute to some of these distinct patterns that we're seeing both within and across racial groups. And so it's through this area that I consider some of the paradox explanations that perhaps physical and mental health or distress and disorder are just not linked the same way for Black folks as they are among other populations. So in one area, I've done this by assessing the mental health paradox directly. For example, I published several studies in the past few years that have assessed the extent to which mental health advantage that we observe among Black folks applies to both women and men across age groups, or whether we see these patterns across various psychiatric disorders. And most recently, I led a paper that was published in the Journal of Health and Social Behavior with Patricia Louie and Chrissy Irving that examines some of these proposed explanations for the paradox, including that Black Americans have more positive coping resources. And in just about all of these cases, we saw that the Black mental health advantage, as we term it, is relatively consistent across all of these various conditions. So while the Black-white distinction in mental health is fascinating, one area that I'm particularly interested in that adds, I would say, another layer of complexity is the within group patterns that we see among Black Americans, which includes the discordance between psychological distress and disorder. So in a study published last year in the Journal of Affective Disorders, we investigated two main issues. So first was whether the determinants of distress and disorder, and in this case, I was looking at depressive symptoms versus major depressive disorder. So the goal was to examine whether the determinants of distress and disorder were the same or consistent. And so trying to understand, are these outcomes shaped by the same risk factors? And then I wanted to know the extent to which greater depressive symptoms were linked to greater risk of depressive disorder. And interestingly, I found that depressive symptoms was linked to major depressive. There we go. I found that depressive symptoms were linked to major depression for white Americans and for some Blacks. However, we really saw some nuance among the Black population. Specifically, we saw that for the majority of Black folks, those who face greater or heightened exposure to social stressors, greater depressive symptoms was not associated with greater psychiatric disorder risk. And so you can see that in the dashed line here. So for white Americans and for Black Americans with lower stress exposure, we see, that expected relationship, but we did not see that for the majority of our Black sample who reported heightened stress exposure. So what that suggests is that part of what we're seeing with the paradox and this discordance between distress and disorder may arise because for most Black folks, distress is not a direct predictor of disorder, and it may be indicative of some resilience or what we call enduring process that's happening. This idea that folks who are used to dealing with a lot of stressors, when they experience elevated depressive symptoms, it's problematic, of course, but they aren't experiencing that heightened disorder risk. So perhaps there are some underlying protective processes that are going on there that need further investigation. So to better understand this, I've added a newer area to my program of research that examines the interconnections between physical and mental health. So social science and population health research has increasingly assessed biological health indicators to really understand some of these physiological processes. And so most of my work in this area has focused on the allostatic load index, which is a multidimensional indicator of the wear and tear on the body due to chronic social stress exposure and persistent high effort coping. But I've also examined individual biomarkers like C-reactive protein and others. And so, as Bree mentioned, I'm gaining new expertise in this area through my participation in the MIWI program, which has been a really great experience and has sparked some great collaboration with other folks. And this past July, I was awarded a pilot grant from the UCLA USC Center for Biodemography. And so my research team and I have recently started a project examining the role of allostatic load in particular and understanding the links between physical and mental health. That work is ongoing, but based on preliminary research, we are finding some really interesting patterns. I'd be happy to talk more about those during the Q&A. So in my second area of research, I evaluate the life course processes through which risk and resources develop and produce distinct mental and physical health outcomes within and across racial groups. And I consider the potential paradox explanation that perhaps risk and resources that shape health have different impacts across racial groups. And so I do this through two areas. First, by examining diminishing returns of high SES among Black Americans, and by assessing the differential impacts of various risk and resources. So most recently, we explored the physiological impact of marriage among women, looking at differences in the significance of marriage for allostatic load among Black and white women. We also have examined the ways that SES contributes to differences or contributes to or shapes differences in access to protective stress buffering resources like mastery, self-esteem, and social support. And I'm also happy to discuss some of these, but for the sake of time, I'll push that to the Q&A as well. And some of these mechanisms we'll be exploring more closely soon. Our research group was awarded a Russell Sage Pipeline grant to examine the role of socioeconomic mobility with goals driving stress and other experiences among Black Americans. Okay, so my third research area is where I identify and assess race and racism related stress and coping processes to understand the varied and often nuanced ways that minoritized racial status can shape the lived experience of Black Americans across the life course. And so it's really in this area where I focus specifically on a lot of the racism related stressors and also developing measures of new forms of race-based stress. And so in one example, we examined the links between early life racial discrimination, or what we call ELRD, and mental health among Black adults. And so given a lot of the paradoxical mental health patterns observed among Black Americans, and with the limited research assessing the role of life course processes and specifically early life experiences, our goal for this project was really to clarify the pathways linking ELRD to psychological distress and psychiatric disorders in adulthood. And so we examined a few different mechanisms for this project. So first, we took a look at the direct association shown here as path A. And our question was, does ELRD have an impact on adult mental health? Is that effect different for distress versus disorder? And if so, how? And so we wanted to consider a couple of potential pathways. So first, cumulative adversity process, which is shown here through path B. That cumulative adversity process would suggest that the reason why ELRD would matter for adult mental health is because people who face early discrimination perhaps are more likely to face discrimination as adults. And it is that adulthood exposure that is really driving poor mental health during adulthood. However, an alternative explanation we refer to as childhood or early life as a sensitive period, shown here with path C. And that perspective really would suggest that childhood is a sensitive period. So when these events, these adverse events like ELRD happen during this early phase of life, it has a deep, long-lasting impact. And so this pathway would suggest that the reason why early life discrimination really matters for adult mental health is because it conditions or alters the way that people deal with discrimination or stress when they face it as adults. And so the reason why we really wanted to kind of disentangle these different pathways and explore this is because for practical reasons, it really helps us to know when it's best to intervene. Do we have to intervene during childhood or can interventions later in life be beneficial as well? So I just want to highlight a few of the main findings for you. So first, to say we did find evidence that people who face early discrimination were more likely to experience discrimination as adults. So there was some evidence of the cumulative adversity perspective. But what's, I think, even more interesting is that we also found evidence for the childhood or early life as a sensitive period explanation. So here we see that as adult discrimination increases, people who did not experience childhood discrimination or experienced it before the age of 13 actually had psychological distress, higher psychological distress when they were adults. And so you can see that here with the green line. The green line represents individuals who reported having faced no early life discrimination. In contrast, those who reported experiencing major racial discrimination as teenagers, which we can see here in the blue line, they actually had experienced less symptoms of distress or fewer symptoms of distress when they encountered discrimination as adults. So these findings suggest that experiencing racism as a teen actually contribute to some resilience against distress in the face of discrimination during adulthood. Similarly, those who experience discrimination during childhood or adolescence were much less likely to develop major depressive disorder compared to those who never faced discrimination or didn't experience it until childhood. And so that are the red and green lines. So what does all this mean? Long story short, these stressful experiences during early life are detrimental for the long-term mental health of Black Americans and have different implications for psychological distress versus major psychiatric disorder in adulthood. But at the same time, the findings also suggest that many individuals are, likely to develop or able to develop some resilience or protective processes from these negative experiences. So, again, I think just demonstrating how important it is for us to assess these experiences across the life course so we can pinpoint those who are at risk, but also better understand how some individuals are able to develop resilience or protectiveness among others. And so in another example, we recently extended this work to consider how ELRD shapes allostatic load, so physiological health, for the older adult population. And we also added an additional layer to really get at that resilience or the protective mechanisms here. So in this study, again, with the Nashville Stress and Health Study, sorry, I forgot to mention the data set. So with the Nashville Stress and Health Study, which is an epidemiological community survey based in Nashville, Tennessee, it was collected with 1,200 Black and white individuals. We did community-based surveys, but then also collected biomarkers among the whole population. I'm also happy to answer any questions about the data source as well. So with this study, our goal was to examine the relationships between early life racial discrimination, adult racial centrality, and adult allostatic load. So similar mechanisms, but really trying to understand the protective role of racial identity for physiological well-being. And so some interesting findings from this study is that we saw that adolescent ELRD conferred slightly higher levels of adult centrality. And we saw that like about 32% actually increased a risk of high adult allostatic load. So for folks who said that being Black was a really important part of their self-concept or their identity, we saw that those individuals reported higher levels of adult allostatic load. However, having this higher level of adult allostatic load wasn't due directly to their higher levels of centrality. So it was a little confusing at first, but then with the interaction findings we saw here, the picture cleared up a little bit. So we saw that ELRD and centrality interact to actually shape adult allostatic load. So what we saw was that higher levels of racial centrality was protective against high adult allostatic load for those who experience racial discrimination as children or adolescents. So again, this really highlights again the importance of the timing of these experiences, but it also suggests that that individuals who experience these events, particularly again as children or adolescents, they were more likely to develop more higher levels of adult centrality, or say that being Black was more important to their sense of self. And then that higher level of centrality was protective for them later in life, and compared to those who had not had those kind of experiences. So the findings here highlight kind of the multiple and pretty nuanced pathways to which racism-related stressors and psychosocial resources like racial identity interact to shape physiological dysregulation later in life. And it really underscores the health significance of racial identity among older African Americans. And as you may know, a lot of the racial identity research to date has really focused on, racial identity development and its impact on health and well-being among younger populations. And so part of my ongoing research has been trying to understand, how racial identity continues to develop and change throughout life with varied stress experiences, but also how it continues to shape health, at these other stages of life as well. And so in my last area of research is where I examine or I kind of put all of this together to really consider a new framework for understanding health and well-being for Black Americans. And this is the study that Bree mentioned during the introduction. And part of it, it refers to the racial self-awareness framework. And part of this work really originated from my dissertation work, actually. And so it started out as the Black and White Spaces study, which was a qualitative research study done back in Nashville, Tennessee, in which I examined, or I really was trying to understand the stress experiences of Black Americans who either lived and or worked in predominantly white spaces. And so really my goal was to understand, the physical impact of, or the physical and psychological impact of navigating, white spaces as a person of color, and really trying to push the stress literature further than, thinking just beyond discrimination, which we all study and we know is important, but trying to understand more nuanced forms of racism related stress, and to understand how those experiences also impact health. So in the Black and White Spaces study, I did very in-depth interviews with 60 African-American adults in Nashville. We also collected survey data from them as well. And from that work, I developed the kind of central tenet of the RSA framework, racial self-awareness framework. And that tenet is racial self-awareness, which I'll call RSA for short. And so RSA is what we call a fundamental but currently unmeasured component of the stress process among Black Americans. And I argue that it really transforms the ways that stress and coping processes both operate and shape health. And so I define RSA as a process of psychological racialization in which individuals come to recognize and respond to the social and psychological implications of their racialized, minoritized racial status within majority spaces and contexts. And so it's just a more complicated way of saying that I really try to, with RSA, it recognizes, it tries to understand how individuals understand or recognize their own racial status and the implications of that racial status within majority context. And so we can think about RSA as that additional cognitive labor that often arises when Black Americans recognize that there may be negative social implications of their minoritized status within these spaces, and that awareness often results in additional efforts to avoid racial bias and discriminatory treatment. So racial self-awareness really builds on this idea to also consider the ways that racial minority status can shape the everyday stress and coping experiences of Black Americans. And so through this framework, I argue that racial self-awareness may elicit psychological and physiological strain and contribute to negative social or performance outcomes. So we can think about things like decreased social interaction, productivity, avoidance, along with our kind of traditional health indicators. And so some of these nuances in the stress process may contribute to some of the paradoxical physical and mental health outcomes that we see among Black Americans. And so through the interviews and surveys, we have kind of developed in understanding and thinking about racial self-awareness as a much broader process. And that goes to show you how the richness of qualitative work can often lead to a much bigger project than you originally anticipated. And so through this work, we have recognized that along with kind of the original or the main tenet of racial awareness, kind of understanding how individuals understand their racial minority status within the space, there are also a few other dimensions to this RSA process. For example, there's racial threat, in which individuals, it's more of the like external or social dimension of the process, in which individuals come to realize or recognize that their identity or their presence in the space may be devalued or delegitimized by others, and that may include unfair treatment or not. And so, you know, under thinking about the threat that may come from their navigation of a particular context, there's racial safety, which really captures more of the internalized process in which individuals think about themselves or how connected they are to other, you know, people of color or Black Americans within the context. And then the racial reality component really focuses on how individuals think about the role of RSA in their lives. I'd be happy to share some of the excerpts if we have a little time, but most often we saw folks talking about RSA as, you know, this is just a part of life. This is, you know, even though individuals aren't going around necessarily saying like, this is RSA or racial self-awareness, the vast majority of individuals, Black Americans, are able to articulate and explain this feeling of awareness, the different strategies that they use within these contexts. And so racial reality really involves the consciousness aspect in how individuals understand the role of this awareness in their lives, whether some recognize it as, you know, this is protective and I'm glad I have this, or others see it as a burden that contributes to, you know, more stress and anxiety in their lives. And so based on this work, ultimately developed a much broader framework that I will say is a working framework. And essentially this framework, the RSA framework of race-based stress, coping, and health, really is an integrative model that brings all of these processes to explicitly think about the ways that Black Americans experience RSA, and how those experiences influence the stress and coping process and ultimately contribute to distinct psychological and physiological outcomes. And so, you know, again, this is a very ongoing work. And this is work that, you know, my research team and I are currently using to develop survey items that we hope to incorporate within nationally representative data at some point. And, you know, we're currently doing an extension project in California, you know, to capture some of the ways that more of a, I would say, a multicultural, a more diverse environment, how the RSA process plays out there. Because at that time in Nashville, it was very much so just mainly dealing with like a Black, white kind of context. But as we know, across the country, there's a lot of different forms of diversity. And so the goal of our current work is to really understand how this RSA process plays out there, and to how it contributes to nuances across different settings. So I'll stop there so we have time for some question and discussion. And thank you so much.
Courtney, thank you for that fantastic talk. Man, I got so many questions, but I'm gonna hold them off for a second. Let me see if I'm opening up for questions from the group first. All right, well, you snooze, you lose. You can ask your question in a minute. So I'm fascinated by your the plot you showed with, I don't know if you could bring it back up, the one that had the Journal of Affective Disorders paper with the distress on the x-axis and the probability of depression diagnosis on the y. I hadn't read this paper, but I need to read it. Can you?
Oh, there it is.
So,
can you see it?
Yes, thank you. So the lines are referring to, or sorry, that within the Black population represented here, there's also this sort of, is this like a perceived stress scale, or sort of it's both like stress and depression stress and, you know what I'm saying? I mean, walk me through that a little bit, just so I understand what's going on here.
Okay, perfect. So in this study and in this plot, we looked at the interaction between stress exposure. And in this study, we measured a comprehensive array of stressors, including chronic stress, recent life events, major and everyday discrimination, lifetime trauma. I think I caught all of them. Yes. So like 5 different dimensions of social stress exposure across the life course. And we did an interaction between depressive symptoms and stress exposure as, predicting major depression. And so what we saw here was that for most folks, and this image combines kind of 2 groups here. So we added the white group in here just so you could see the comparison. But among Black Americans, there was a significant interaction between depressive symptoms and stress exposure, such that individuals who had greater exposure to stress, the relationship between depressive symptoms and major depression was essentially 0 for them. And that's what we see with that dashed flat line. Whereas for Black Americans with low and moderate stress exposure, we saw that kind of expected increase in major depression risk as their levels of depressive symptoms increased.
I mean, this plot's fascinating for lots of reasons. I mean, one of the things it really helps. So first of all, I'm also just like so thrilled that you're. Oh, sorry, Jana, do you ask your question first before I editorialize what I think I'm looking at?
Thanks, Bree. It's more of a clarifying question.
Yeah.
First of all, amazing talk. That was so interesting. I have like tons of notes, and I'll just try to keep this to one single question. I'm not a mental health researcher, so can you help me understand? I think, how you would capture the presence of depressive symptoms, but then in terms of major depressive disorder, does that require a diagnosis, or how are you measuring that piece?
I'm glad you asked. So in the Nashville Stress and Health Study data, in many major epidemiological studies, they use like the CD or similar measures, which essentially is not a clinician diagnosis, but it's assessing their essentially assessing their risk through these community-based surveys. And so we wanted to use the measures that most epidemiological surveys use, because that's really kind of how we were trying to make sense of the mental health paradox, right? And so that's really, the mental health paradox has really highlighted that we see, yes, Black Americans have these high levels of distress or depressive symptoms, like with the CESD and a lot of these other similar types of scales. But when it comes to their risk for major depression based on the CD and similar indicators, we see that it's quite low. So they're not meeting the thresholds for major depression. And for this one specifically, it was for chronic major depression. So indicative of, those who've had it both within the past year and who reported both lifetime and past year.
Okay, so two different scales, essentially. I'm looking at Bree's comment too, right? Two different scales and their discordance. Is that right?
Yeah, this is like this, I want to use like an expletive, but like this challenge that we have in the mental health field where our distress scales, if you will, like the SESD in particular is sort of the major offender here. It is show, they're not diagnostic. That is, they don't, and by diagnostic, what I mean is a instrument that is designed to mimic what a psychiatrist would do. So that is, that it is assessing diagnostic and statistical manual criteria. It is asking the questions in a manner that's consistent with how a clinician would do so. And then it applies an algorithm that determines whether or not a clinician would likely say you meet criteria for major depression. What the SESD does is just sort of ask you how you doing in the past 2 weeks. And that is not the same as a clinical psychiatric interview. And so the challenge is that we should expect those to be behaving in the same way, right? Well, if you have major depression, you probably also have had a bad 2 weeks. But specifically as it relates to racial group differences, we don't observe that. That is, we see African Americans, as Courtney talked about, report higher levels of distress, but they're less likely to meet criteria on these diagnostic instruments. But what is so beautiful about this graph is that, so part of the argument as to why the diagnostic instruments maybe are showing what they're showing, which is less depression, not just among African Americans, but among Latinos, among Asian Americans, right? Pretty much every minority group in the United States has better mental health than non-Hispanic whites. Is that, well, people don't want to admit to symptoms. But that can't be true if this graph is true, because people are very willing to tell you about their distress. They're very willing to tell you about their stress. And they don't know what's behind the scenes. Like when you go through this, you have no idea that there's an algorithm behind the scenes asking, that's going to figure out that that's not how these things are assessed. And so it's, the notion that people either don't want to tell interviewers about their mental health, or I've even seen kind of bizarre arguments that like people aren't aware like of their mental health, like they don't. And it's like, if that were the case, then everyone should also have low rates on this, or not tell me about their symptoms on the SESD, because there's nothing that magical about when I say, do you feel happy, which is a symptom of the SESD, versus have you had 2 weeks or more where you felt sad, blue, or depressed, right? They're both self-report. They ask you to reflect on your mental state. It's Jenna, your comment's really great, because as somebody who does this work, right, I forget that sometimes when people see major depression, they think, oh, that's a clinician diagnosis, and maybe African Americans less likely to get to a clinician. Sure, they are, but that's not what this is, right? And so it's really important to kind of understand to have that it's such a great reminder that even though this nuance is very, like, definitely part in my subfield and Courtney's subfield, like it's not known widely within the epidemiology.
Yeah, and it like really helps me understand the paradox, right? Like,
yeah,
it's in the lived experiences, essentially, right? What you were saying, Bree and Courtney, it's not that people aren't reporting their symptoms or that there's a lack of access to care. It's like something in the way that the symptoms are being captured. So thank you. That was helpful.
Thank you. Yeah, because this study, I think, for our group really sparked some interesting questions, and I really kind of motivated us to try to understand. It's this interesting combination of, stress exposure, the lived experience, and how, the challenge that we all face as researchers. How can we best capture what is so evident, particularly in our qualitative work? People are able to express this all the time, but how do we capture this and understand it based on the measures that we have, right? And so, that's kind of been our motivation with trying to delve deeper into kind of some of these nuances with indicators like racial identity or like we're doing a lot of work now with John Henryism, but it's like high effort coping, because some of the, a lot of these resources have, you say, like a double-edged sword kind of. There's a nuances within this population that I think are really interesting and can one day help us to understand kind of what's going on with this paradox.
Yeah, I mean, I feel like this is exactly, I mean, I don't know if you ever met James Courtney, but I know that he would just be thrilled with what you've presented here. I mean, it's exactly what he wanted to see happening with his model. Can you talk a little bit about, I mean, I don't know what the state of the world is and sort of getting this sort of new measures that I really also love, just like the closing here with the qualitative work and how that's informing the development of new measures. But is there, can you kind of speak a little bit to that process or sort of where that is right now?
Yeah. Well, as you know, it can be very slow going. I'm working with, I have a beautiful research team of my, all the way from undergrads to doctoral students and one postdoc. And so, we've just been doing this kind of slowly but surely, working through to develop the survey measures. And now, like I mentioned, we're doing kind of an extension in recognizing that, the work in Nashville was kind of one particular context, and we wanted to see how this works in other contexts as well. And so kind of the next steps after we kind of finish the West Coast addition to the project is, to either do like an R01 to do this work at a much larger scale, and I'm anticipating that, this will be something that will be a multi-year project for me. But I'm really looking forward to the opportunity to use these survey measures of the RSA process, in addition to, our typical mental health and physical health measures with biomarkers, because, as you know, there's very limited nationally representative data that cover any of these psychosocial factors besides the NSAL, and as the years go by, that those data get increasingly older. And so, I think I'm hoping that this just becomes an opportunity to kind of spearhead a new data collection effort at the national level so that we can understand all of these processes among this population. So, it's going, but I don't want you to think that it's going to be next year. It'll be a little while, but we are looking forward to that process. And it is definitely kind of like my main focus.
And I think it really does show, it's like, we're looking for certain things, like those are the measures, right? So it's like we're under the lamppost because that's where the light is. But, it is, it's been tremendous even in the 10 years or 15 years I've been kind of working in this, like getting these questions, like how much sort of everyone sort of realized, like, oh my God, like we just, like the emperor has no clothes. We literally had no very, like all these national data just were kind of built on the assumption of, there not only did, I'm talking to the choir here, but I just think even to begin with when you talked about the middle class African Americans and like that, like let's look within this population. I mean, I'm just really that heterogeneity within as a means to really understand processes and mechanisms that are just they're not even in the brains of people who are thinking about these big national surveys. I just think is really tremendous. So we are at time. Oh my gosh. Wow. All right. Well, Courtney, I know I'm going to see you in a few days. So, but anyway, I just want to please join me in thanking Courtney. If you would love to get a hold of her, she gave you her Twitter handle and you know how to get her at UCLA. So please again, join me in thanking Dr. Thomas Tobin. Thank you.
Thank you so much, everyone. It was really
all right.
great.
Thank you. Wonderful. Have a great one, everybody. Bye.